Good evening, everyone in India, and good day, everyone in other parts of the world. Uh, I am Sujit Rajan, a pulmonologist in Mumbai, Bombay Hospital and Bhatia Hospital, and I'm privileged to moderate this session this evening on rheumatoid arthritis, ILD. Very specific topic. Uh, and my area of interest is interstitial lung disease and respiratory palliative care. Next slide. I'm really delighted. Next slide, please. I'm really delighted to introduce three guest faculty. The first being Sonia Danoff from Baltimore in the United States. Sonia interest is interstitial lung disease, specifically connective tissue disease, ILD, and she's the senior medical advisor to the Pulmonary Fibrosis Foundation Care Center Network and co-directs the ILD clinic at Johns Hopkins in Baltimore. So welcome, Sonia. We also have Vijay Hadda, a very dear friend from Delhi, the northern part of India, who is at the All India Institute of Medical Sciences, no stranger to respiratory medicine in India. And as you can see, he has over 300 publications and has been one of the best reviewers of our journal, The Lung India. One of the significant parts of his work in ILD is that he's been the national lead of the ICMR network of pulmonary fibrosis, which is generating some amazing demographic data in ILD in our country. So welcome, Vijay. And finally, Padmanabha Shenoy, who is the rheumatology arm of our meeting. Shenoy graduated from Kerala and post-graduated from JIPMER in Pondicherry, which is the other coast of India, from the western coast to the eastern coast, and has done some tremendous work in rheumatology. His research interests are the immunogenicity of COVID vaccines, scleroderma, and palindromic rheumatism. He has more than 50 publications in peer-reviewed journals, including Lancet Rheumatology and the NEJM. And so I welcome all of you to this evening, and I'd hand over to Sonia to share her slides to present her first case, which we will discuss, and then another case, which we will discuss, followed by a short 10-minute presentation by Sonia, and then we'll ask some more questions to our three faculty. Over to you, Sonia.
Thank you so much. It's such a delight to be able to join you today, and I really appreciate being invited to share some time with my colleagues in India and talk about a very important topic, which is rheumatoid arthritis-associated interstitial lung disease. So I'd like to start off by talking about a couple cases which I think are illustrative of the sorts of patients that we see daily in our clinics. And I hope that this helps to illustrate some of the complexity of the care of patients with RA-associated ILD. So the first case I'm going to talk about is, and these are both cases from my clinic, a 78-year-old gentleman who was referred for possible ILD. His sleep provider had examined him and noted that he had some crackles on a chest exam and therefore referred him to have an X-ray. The X-ray was abnormal. When I spoke to the patient, he told me that he had noted some dyspnea on exertion for about 3 to 4 years. And he'd also noticed in the 6 weeks prior to his clinic visit that he had developed a dry cough. His past medical history was really only notable for diabetes. He'd had some surgery before, some lower back surgery. And when I spoke with him about his review of systems, he did mention that he had occasional swelling and redness in several of his MCPs. But he had no diagnosis of arthritis or any other autoimmune disease. His only medication was metformin, and he had no medical allergies. In speaking with him about his history, he had had very rare distant tobacco use. For his entire career, he'd worked in an office and he had no obvious exposures. His family history was notable for the absence of any history of interstitial lung disease or connective tissue disease. On exam, he was a very pleasant gentleman, obese, in no distress and not on oxygen. And as is a very common problem in our US clinics, his BMI was 30, almost 37. His oxygen saturations were 97%. When examining him, his lung fields were of moderate size to percussion, and he had, as noted by his other pulmonologist, he had lower lobe crackles. His exam was otherwise relatively unremarkable, aside from the fact that on extremity exam, he had boggy, swollen joints affecting both of his MCPs. And this was his first set of imaging, which was done in follow-up of that chest X-ray. And although I'm only showing you a few slices of this image, I think that what you can see is that there is a largely peripherally distributed reticulation pattern. I think that the other notable finding on this is that he actually has relatively little lung involvement with this process. You may be able to discern that he has a very small amount of traction bronchiectasis, typically, particularly in this anterior distribution. And then as you go further down on his imaging, you can see that he has a little bit more reticulation at the bases than he did in the upper portion of the lung. Now, these were his first set of pulmonary function tests. And I think that what you can appreciate from this is that while he has very well preserved lung volumes, that he actually has a significantly reduced diffusing capacity at about 60% of predicted. So a gentleman who, if he had had only spirometry, would have potentially been seen as having neither obstruction nor restriction, but with that diffusing capacity, you can appreciate that there's actually a significant impairment in his oxygen uptake. So again, this was a gentleman who had no prior history of connective tissue disease. And so we are in the practice of sending a broad serology at the beginning of evaluation. And his studies were notable for the fact that he had a number of negative serologies, his ANA, SEL70, Rho law, RNP, his myositis panel, and his ANCAs were either negative or normal. However, his SED rate was elevated. One could argue that age-adjusted, that's not dramatically elevated, but is somewhat elevated. However, his rheumatoid factor and his CCP were both positive, and his CCP was strongly positive. He did have a hypersensitivity panel, which was negative. So just to bring you up to date on this case, his pulmonary symptoms actually were quite stable. And initially we monitored him with pulmonary function tests. However, he was evaluated by rheumatology and started on hydroxychloroquine and had very limited response to the hydroxychloroquine in terms of improvement of his joint disease. And he subsequently, with the discussion with both ourselves in pulmonary as well as rheumatology, was initiated on methotrexate for control of his joint symptoms. And in fact, his joint symptoms improved dramatically with him on methotrexate. And so I'm going to stop sharing here and ask ask Sujit to lead us in some questions.
Yeah. So, Vijay, this man is obese, pretty well preserved lung function. What would you do at AIMS or at your institute when such patients get referred?
So, Sujit, I think one thing is clear that this patient is having some autoimmune disorder. And going through the clinical presentation, we are almost certain that he is having rheumatoid arthritis. Other things which I found during this presentation is his disease activity seems high because still he is having evidence of active synovitis. The ESR was high. And then the other thing which I noticed were the serological markers, the rheumatoid factor as well as anti-CCP. they were quite high. So to me, this patient is I will keep this patient in a group where he may have high risk of development of interstitial lung disease. So this patient was well worked up at John Hopkins. They thought probably may have ILD. First they did a pulmonary function test and then radiology. At our institute also, we will do almost same. The patient will come to us, then first in all patient we will assess clinically with symptoms, predominantly respiratory symptoms, dry cough or dyspnea. And then the other thing is a little controversial, but at our institute, almost all the patient we subject to a spirometry at least with DLCO. And based on that, we proceed further. So this is in nutshell what we do at our institute.
Sure. So you did mention that he is at high risk of ILD. He has an ILD actually, Vijay. So that's the concern area. And I noticed Sonia's institute started him on methotrexate after a failure of HCQS. Shenoy?
Yeah. So I think in rheumatoid arthritis, ILD has to be seen whether it's symptomatic or asymptomatic, and his lung disease. So I think we should be very cautious in starting methotrexate being diagnosed with a base level interstitial lung disease, because it has been shown multiple times that methotrexate pneumonitis is a risk. But having said that, if somebody is not a methotrexate, they have not developed interstitial pneumonitis, it's okay to continue. That is the general consensus. But most of the time, we have seen again and again, methotrexate pneumonia is a very rare complication, and people are with a risk-benefit ratio. You can start methotrexate, but it has to be with ultimate caution. But I would have preferred sulfasalazine probably, which is another disease-modifying drug, and looked at the lung function, whether it's deteriorating or not, probably repeat a CT scan at the end of 1 year to see whether there is increase in fibrosis, and changed my strategy accordingly. So my first slide would have been slightly different. You can debate this, whether you can start methotrexate or not, but still I would have started methotrexate because, at this age, somebody developing a methotrexate pneumonitis, chance of this thing is high. And it has been shown in a lot of studies that somebody has a background interstitial lung disease, chance of developing a pneumonitis is slightly on the higher side.
So Sonia, he's obese. He has a dry cough. He's got an ILD. What made you start methotrexate? Which Shenoy clearly doesn't want to.
Yeah, no. And I think that you're really touching on one of the most complicated parts about rheumatoid-associated ILD. So I would say that this gentleman, who was a former smoker, has a lot of imaging findings and pulmonary function findings that are consistent with the fact that he was a smoker. I think that he actually coughed because he had reflux, and I did not actually talk about that. But the intervention we made, which I did not discuss in this, is we had him lose weight. And with losing weight, not only did his lung function improve, but his cough resolved. And so in this situation, he does clearly have interstitial changes, and he has fundamentally, you could argue he has ILD because he has abnormal PFTs, but his symptom burden was actually related to something that was not his ILD. And because he had very minimal interstitial changes, and as both Dr. Shenoy and Dr. Hada have very nicely pointed out, we follow our patients very carefully. We actually see our patients about every 3 months in their first year, and follow pulmonary function testing and symptom burden, as well as imaging as appropriate. So for this patient, while I absolutely agree that you have to consider the risk of methotrexate and methotrexate pneumonitis, he seemed to be somebody who actually had very active joint disease and relatively inactive lung disease. However, we were the ones who helped him make that diagnosis of RA because of the evaluation for the ILD. And I think the point is extremely well taken. One of the things we really try to do is to educate our patients on the risks of methotrexate pneumonitis. So we educate them that they need to, if they start to cough when they start methotrexate, they need to tell us right away so we can stop the methotrexate.
So yeah, I think it is tricky. There's no one clear answer here. But Vijay, if this patient now is on methotrexate or sulfasalazine, would your lung function monitoring be different, or would it be the same for such a patient with a baseline ILD?
So I think as all of us agreeing that although methotrexate is a real potential to cause lung toxicity, but overall the risk is very, very low.
Right.
Especially we see the recent trials, which
Sure.
in our cities, the reported rates are very, very low. Yeah, if I remember correctly, in one study was reported less than 0.3% or so.
Sure.
So the risk is very low, but still, once you have started, then we should keep in mind that this can lead to worsening of symptoms. If there is any, then we should not ignore that. First thing is that. The second thing is, I think the follow up with spirometry, DLCO, and if you have lung volumes, that should be same, approximately 3 to 6 monthly.
Sure.
At our institute, most of the time our patient comes every 3 monthly, so we are following that. But usually 3 to 6 months is the appropriate period in most of the patient where we can keep on follow up with spirometry and DLCO, and most of the time we will be able to catch that.
Sure. So a question to both you and Sonia here. 3 months down the line, this gentleman's lung function drops by 5%, which is not a huge drop. He's lost a little weight, but he's dropped 5% vital capacity. Vijay, would you consider antifibrotics here?
Yeah, so this is one thing which is probably a hot topic nowadays, that how to identify progressive fibrosing ILD or progressive pulmonary fibrosis in any ILD other than IPF. So at this time, I would keep two possibilities. Is it the disease itself or the lung fibrosis has progressed? And 3 months may be little too early to say that it has gone into pulmonary fibrosis.
Sure.
The second thing is, at this point of time, definitely I will not consider antifibrotics. I would go for immunosuppression because rheumatoid is mostly inflammatory disease. And if we focus more on inflammation, especially in initial part, that will be probably more fruitful. Unless patient is grossly showing honeycombing, in those cases, probably I may be a little bit conservative. Otherwise, in this case where there is no honeycombing and early ILD, and if there is little worsening, immunosuppression optimization is the first step.
Sure. And Sonia,
Corticoid or maybe a second drug that one can discuss, but definitely immunosuppression with the first line therapy in these cases.
sure. No, so I'll refine that question further for Sonia. 5 to 10% with a little more reticular opacity if a scan was done at 3 months versus a 10% drop. How would that change your management?
Yeah, I think that, you've really heard from Dr. Hada the kind of the balance that you have between deciding if you have immunosuppressed sufficiently versus whether this is actually now becoming a progressive fibrotic disease. And I think that I would have exactly the same approach, which is that I would initially think about whether I had immunosuppressed sufficiently, and I might look at other markers of inflammation, and I would certainly talk with my rheumatology colleagues about whether they felt that they were getting good control of joint disease. And I might actually add another immunosuppressant in that situation. And I mean, what I would probably add at that point in time would be rituximab, because it has very good coverage for lung as well as for joints. And certainly, we've already talked about the fact that methotrexate was potentially a challenging decision initially. So we would also kind of revisit the question of whether there were any symptoms suggestive of whether there was a methotrexate pneumonitis.
Sure. Makes sense. Yeah. To look at methotrexate pneumonitis, consider rituximab. I think I will put it across to Shenoy as we get to the end of this case. With which drugs, Shenoy, would you be most concerned, lung toxicity? Because in RA, one thing is methotrexate. We heard that that's pretty rare, but there are a lot of drugs that you use for RA.
Leflunomide.
And so leflunomide, and
Yeah, leflunomide LP,
yes,
anti-TNF,
and
probably abatacept.
abatacept.
These are
And
the three drugs. Probably, yeah. Rituximab, I will prefer rituximab. But
sure,
I think when the FVC, slow decline in FVC is unlikely to be because of methotrexate, and methotrexate pneumonitis we know is
yes,
methotrexate doesn't cause ILD. Let us get out of that concept.
sure,
Methotrexate will not cause ILD. It will cause only methotrexate pneumonitis, which is an acute disease. All of us know that.
correct.
So
I remember reading one commentary that if it happens in the first year, be
yes.
a first year of usage, just be a little cautious, and I agree. There's never a 100% correct answer here, and I think the choice and the drugs you mentioned were obviously of concern. But anything in the new guidelines, the ACR ILD and the EULAR treatment network,
Almost similar, almost similar, but antifibrotics are not the first choice. Like Dr. Hada told, antifibrotics should not be never given first choice, but probably other drugs can be given. Tocilizumab, maybe rituximab, tocilizumab, tofacitinib. All
yeah,
these things have some effect, good effect on the lung, especially the implicated from whatever scleroderma interstitial lung disease studies we have. These drugs are likely to be more effective.
sure.
But
And
considering
Sujit,
so,
just one point. Sorry, I
Please,
interrupted. So
please.
I think at this point of time, we should also consider some kind of infection, especially in our setting.
Yeah,
Something that can also present like this.
got it. With
So
a drop in lung function, you're talking
yes,
about. Got it.
yes,
Yes,
yes.
yes,
Or
of course.
respiratory symptoms. The
Absolutely.
indolent infection like tuberculosis, which
Yeah.
can present this. So in
And I
every
think
patient,
we often forget common sense in our, desperate desire to identify ILDs and see the scans, like as Sonia mentioned, the reflux cough, simple things that can be managed pretty easily. Absolutely, Vijay. Uh, Sonia and Vijay, one hypothetical situation before you go to the next case. If this patient had a UIP pattern on the scan at the beginning, would you still be okay with methotrexate, Sonia? Uh, and would you consider upfront antifibrotics based on the inbuilt and trail data? Uh, any thought here, Sonia?
Yeah, so just, I think that this is an area where
It's not your
yes,
case.
I think this is an area where there's a lot of controversy. And just to point out that the inbuild data really only looked at patients who had progressive fibrotic disease. So there's really not any data for upfront use of an antifibrotic. But I
Right.
think that it actually expands our armamentarium if you have a patient who you've immunosuppressed, you and your colleagues in rheumatology feel that the patient is adequately immunosuppressed, and they then develop progressive fibrotic disease. But that would be several steps down the line for me. And I find that imaging is a little bit challenging in CTD-ILD because we certainly see patients who have UIP patterns, but don't necessarily progress in the way that an IPF patient would. However, I do think that it is an important thing to think about when you start is where you're going to change directions. Like at what point are you going to say, I've done everything that seems reasonable from an immunosuppression standpoint. I've looked at infection, and now I need to really think about fibrosis.
Sure. Vijay, would you also agree? UIP upfront antifibrotic? Would
yeah,
you
I think more or less I agree with this. If I need to treat this kind of patient, definitely I will focus more on immunosuppressive first. It will
Sure,
never be antifibrotic alone at least, or it
sure.
will not be first line drug. So that message should go clear that the antifibrotics are not the first line drug. We
Right.
should always give a good immunosuppressive trial before jumping onto antifibrotics, even if it is, let us say, UIP pattern. Although my statement may be a little bit controversial, but at this point of time, whatever data we have, there is no suggestion that we should jump on direct starting antifibrotic, especially alone as a first line therapy.
Sure. Thank you. Thank you, Vijay. Sonia, maybe you could go to the second case, and there are multiple questions coming in from the audience. So as you pull up your slide for the second case, I'm just looking at what is the dose of pirfenidone to start with. I would say the usual dose, if it is progressive pulmonary fibrosis, I guess you could consider the usual dose. Rajiv Ranjan and Asmita's question on methotrexate causing ILD. I think the panelists answered it that this is pretty rare. Uh, Do you even think of RA-ILD mimicking UIP also do relatively very well compared to idiopathic? I couldn't understand the question from Asmita. There was a little.
What she's trying to ask is whether IPF RA-ILDs has better prognosis.
Yeah, so that's this.
Don't know.
Yeah, so we
Really
don't
not.
know that actually. There's one study that showed it's progresses pretty fast, I recollect. And as Sonia rightly said, not all of them progress really. Some of them can remain stable even with honeycombing. And I'll come to the other questions as we go along. Sonia, over to case 2.
All right. So this is really a very different sort of case, but I think is really illustrative of the other face of patients who have RA-ILD. And this is a patient who actually we know that she has a history of RA, and she's being treated for her RA, and she now develops shortness of breath and cough. She has a past medical history notable for Hashimoto's thyroiditis. So really, obviously multiple presentations of her autoimmunity. She also is a former smoker, originally from Iran, lived in Germany and the US for many years prior to when she came to clinic. Her family history is interestingly not notable for either CTD or ILD. However, she's reached a point where her dyspnea occurs with less than one flight of stairs, and her current medications include methotrexate and a TNF inhibitor. She has no known allergies. On exam, pretty consistent with our clinics, she is also obese with a BMI over 35. She has 4 out of 10 pain in her hands. Her SATs are 99% on room air in the clinic. On exam, she has extremely small lung fields, bilateral lower lobe crackles, and on extremity exam, she actually has ulnar deviation of her MCPs. When her labs are drawn, she has extremely high antibodies with a rheumatoid factor of 1100 and a CCP of 177, so both strongly positive. And this is her image. And so again, what I think that may strike you as in the few slices that I'm showing you here is that she actually doesn't have much in the way of reticulation, and she has pretty much nothing in the way of honeycombing. But what she sort of has that you may appreciate is that she looks like she has maybe just a bit of ground glass that you can see better in the bases. And you might also see that she has just a little bit of peripheral sparing. That's most visible on this lowest image. So again, a patient who has a fairly high symptom burden, but has fairly mild radiographic changes. So let's go on and just look at her pulmonary function tests. And so these are her pulmonary function tests. And as you can see, her forced vital capacity is, in the modestly reduced range, as is her total lung capacity. But interestingly, her diffusing capacity is actually as a percent of predicted higher than is her FEC or her TLC. And although I know there's a lot of controversy about looking at this, her DLCO to alveolar volume is actually greater than 100% predicted. So let me stop there and just ask
Yeah.
for us to continue our discussion.
Yeah. So lung symptoms, abnormal scan, low lung function, not very low, but low. She's obese again, I notice. Vijay, what would you do from here?
I think this case, ILD is there, and both radiological as well as physiological impairment is there. So we need to take a decision to start treatment. And I hope that she is already received a good amount of DMARDs for the rheumatoid arthritis. I don't know about that, whether this disease, although with parameters look like it is still active disease there. And then there is some evidence that that is showing that some long-lasting joint abnormalities are there. Probably they are showing healed lesions. But CT scan, if you see, there is no honeycombing, not even bronchiectasis or broncholectasis or traction bronchiectasis. So that is not there. Predominantly GGOs. So if I need to treat this lady at this point of time, again, as I told, I will start immunosuppressives. Maybe at our institute, usually it is methotrexate to go agent. Other, probably we don't have much experience, but most of the time it is rituximab. Sometimes we give oral steroids also, but methotrexate is one which will be combined with maybe steroid for short duration of time with rituximab. So this is how I will go.
Sure, sure. Sonia, how would you go?
Dr.
Here?
Sujit, if I can ask a doubt.
Yeah, of course, Shenoy, of course.
Dr. Enough. Was we as anti-MPO done in this case, Anka?
Yeah, she was ANCA negative.
Okay.
Yeah. So, like all good cases, there's always some piece of information that you don't get. So this patient actually was had a lot of difficulty taking her medications regularly, and you notice that her antibody levels were really high, and she had evidence of damage on exam. She's quite young. It turned out that she would go on what we would call drug holidays, where she would just stop taking her medications. And one of the big concerns that I had with her, as you heard also already from Dr. Shenoy, is that she was on a TNF inhibitor. And when I talked to her about the timing of her symptoms, sort of in relationship to when she started the TNF inhibitor, she thought that her symptoms worsened, and that was actually part of the reason she wasn't taking her medications, is that she thought that her dyspnea actually worsened when she was taking her TNF inhibitor. So, one of the things that I always do, and in a patient who's already on medications, is ask about the time relative to when the symptom burden started, whether a drug has been started or whether a drug has been increased in dosing. And then think about whether the first step is take away the drug and let's see what happens next. And so there were a couple of challenges with this patient. The first is that I was concerned the TNF inhibitor might be contributing to it, just as Dr. Shenoy had mentioned. The second was that she was really not taking her medications regularly, so wanted to get a medication that she would be kind of consistently exposed to. The third was that she was actually still smoking intermittently, and so we got her to stop smoking. And then the last thing, which I think is very important in our patients, is that she was really very obese. And I thought some of the fact that her lung volumes were so low was actually related to her, to her truncal obesity. And so we got her to lose some weight. But we did actually start rituximab in her because that was a drug where we knew she would be consistently exposed to it and not have the risk of her coming on and off of it. I was very concerned about starting a medication like prednisone given her obesity and also her intermittent use of medications. So I'd be very interested what my colleagues would have done in this situation. Sujit, you're muted.
It's quite sorry about that. It's fascinating, this case and how you described what you would do, Sonia, because I think we have a question actually from Delhi that how are you getting the weight down in a 78-year-old patient? So this is a big challenge for I've had this as well. Older patients we often just give up on the weight part, and they say that, look, my quality of life is badly compromised if you make me go on a diet. Any thought there, Sonia?
Now, Dr. Sujit, now tirzepatide is there, Mounjaro, Wegovy, all of them help. They actually help. Those patients who are easily decomposed, it actually helps.
Do you use a lot of GLP-1?
Yeah, we use.
Sonia?
Yeah, we use.
Oh, we are now using them much more. So what our first step is always exercise, because again, we have a very sedentary population. So all of our patients will go to pulmonary rehab. Many of them feel better when they go to pulmonary rehab because it's actually the first time that they've exerted themselves consistently on a kind of an increasing scale. So if they had tried to exert before, they would just feel so short of breath they would stop. So we do pulmonary rehab where we often will see some weight loss. And then, trying to get a patient to commit to a longer term exercise program. And then we, prior to the use of these GLP medications, we would actually have some patients go through bariatric surgery if they were really obese. But
Sure.
now we are definitely trending towards using the GLP medications because we're not looking for a lot of weight loss. We're just looking for some consistency and some, getting people down. Usually 5% is enough, or 5 pounds, 5 to 10 pounds is enough to really start to make a difference. And then once they see that they're less dyspneic, they then will kind of be more consistent in terms of addressing that. But the quality of life issue is a very important one. And I think it's also a really important one as we think about the medications that we give our patients, both pill burden, like how many times a day you have to take a medication, and also the side effects of the medications that we give. So I think that that's a really critical thing for us to think about.
Vijay, would you do anything else as Sonia is going to now start a short 5 to 10 minutes presentation on RA-ILD. And Sonia, maybe you'd like to pull up your slides as I ask Vijay what you would do different. I mean, she mentioned some very important points, Vijay. Any thoughts from your side?
I think the most of things has been covered. Probably I missed that drug history, TNF alpha inhibitor, which can sometimes cause this interstitial shadows or maybe kind of a pneumonitis or interstitial lung disease.
Come again. I didn't hear you, Vijay. So I
So
didn't hear you clearly.
I missed one part, so which this Sonia have brought out clearly that sometimes
Yes.
the drugs which are used to treat the underlying autoimmune disorder, in this case TNF inhibitors,
Yes.
that may also cause
Yes.
disease. So we should also focus on those, that whether this lung condition is because of drug or not. Otherwise,
Sure.
most things more or less we will also do the same. GPL probably still not very commonly being used at our institute. Otherwise, that is a good option to reduce weight. And we have a dedicated obesity clinics also where we send patient and few patients undergo pediatric surgery also. As far as pulmonary rehabilitation is concerned, that I think one of the intervention which has maximum fruit, the
Sure.
most fruitful intervention in patients. But
Sure.
problem is the many patients who are coming to me, they are coming far from Delhi. So they will have practical issues and they don't have any facility to near their house. So that
Sure.
is one thing which I face. But those who are able to enroll in the program, when they come back after 8 weeks or so, they give such a positive feedback that they will say that this pulmonary rehabilitation have changed our life. So if somebody has this facility, I will suggest that pulmonary rehabilitation is one which one should actively look or offer to every patient.
Yes. And I think our academic partner for this CIPLA has an online rehab program also running across India, which is just amazing to see pharmaceutical companies helping in that space. And that helps bridge that distance, Vijay. Great. Sonia, please, a few minutes on RA-ILD, a few points that we could take home here for younger postgraduates also tuning in from across the country.
All right. So I just wanted to spend a minute talking about sort of how we think about RA-ILD. And some of this is going to be a review, but I think it's really important to frame this question. Often when a patient with interstitial lung disease presents, the question that we're really asking ourselves is this IPF or is this not IPF? And I think that making that distinction is actually the most critical piece in our evaluation and ultimately getting patient to the correct treatment. And so obviously the things that are the not ILDs or are the not IPFs are those where there's an identifiable cause of the ILD. And again, just, things that we all know, the connective tissue diseases, the occupational exposures, environmental triggers that cause hypersensitivity, medications that we talked about, the granulomatous diseases, immunodeficiencies, and then I think that there's actually probably a large unrecognized hereditary or genetic group of interstitial lung diseases. And so I just wanted to point out that when we think about the autoimmune diseases, we really are talking about a spectrum of diseases, all of which are affected by interstitial lung disease. And so if you think about the prevalence of these diseases, one of the reasons that it's so important to think about RA is that it's actually incredibly common. So somewhere between potentially 1/2 to 2% of the general population. So the individuals at risk are extremely high in comparison to other autoimmune diseases, which still are very common. Now, when you go on and think about, well, if a patient has RA, how likely are they to develop clinical ILD? This is a little bit of what we talked about earlier. It actually turns out that although we see a lot of interstitial changes and interstitial abnormalities in patients with RA, they actually are relatively non-progressive and tend to have actually a lower frequency in comparison to, say, some patients who have polymyositis or dermatomyositis, where as many as 80% of patients who have some evidence of interstitial lung disease actually have clinical ILD. And then you can look at the HRCT, which is such a key component in identifying patients with ILD. And again, 20% of patients who have RA will have CT evidence, but only 8% will actually have clinical ILD. So what that suggests is that it is very common to see these abnormalities. When you see them, you really need to think, is that what's causing the problem? Very much like the first case that I presented. So I mentioned this briefly as I was talking about the patients. We actually do a very broad screening serology for new ILDs. Oh, sorry about that. And part of the reason we do that is because very often a patient's ILD actually can precede their clinically evident autoimmune disease. I'm very interested to hear my rheumatology colleague what he would think about this, but we do a very broad initial evaluation. And part of the reason that we do that is because after that first period of time, you really start down a pathway that will take you to a therapeutic. And if you go down the wrong pathway, you may miss the boat. You've heard us talk a lot about immunosuppression versus antifibrotic. And I think that this is exactly where you need to be thinking about it. And the other thing that we really need to think about is whether there are also environmental triggers, because those are things that can be mitigated, which may actually change patient outcome. Now, part of the reason why I think it's very important to think about RA is that RA actually can affect many different portions of the lung. And although we're really focusing on interstitial lung disease today, it can have multiple manifestations, including airway disease. And so just yesterday when I was in clinic, I was talking with some of my colleagues about a patient with RA who has a subglottic stenosis. And you can see many different types of airway disease, including bronchiolitis and bronchiectasis. You can see vascular disease with vasculitis. You can see parenchymal disease. We've talked a little bit about the drug toxicity. So part of it is that RA is just incredibly diverse in the way it can present in the lung. And this is a very nice algorithm that was developed just really thinking specifically about patients with RA-ILD. And again, it really highlights these two pathways. One is where you know that a patient has rheumatoid arthritis, and the other one is where you don't know, where a patient is really presenting for ILD, and you're the first person potentially asking the question about whether there is an autoimmune condition. And again, I think it is very valuable if you have this available to have a multidisciplinary discussion with a radiologist and other colleagues, because I think we really are better in thinking about how to address these problems when we do it as a group. I did want to point out the fact that although we talked a little bit about the fact that RA can present as a UIP pattern is sometimes lumped together more with IPF because of that, it really can manifest in a variety of radiographic patterns. Just as I pointed out with that, the second patient who had a pattern that would have been more consistent with an NSIP pattern. So unfortunately, it's not as simple as, oh, if I see UIP in a patient who I think has an autoimmune flavor, then it's going to end up being RA, or I see a patient who has NSIP, therefore I can rule out RA. In fact, there's a lot of manifestations that you can see in the lung. And I just wanted to kind of illustrate this with a very nice article looking at imaging in rheumatoid arthritis. And really what you can see is that there is this very diverse group of radiographic manifestations, everything from sort of a classic UIP with lots of sort of honeycomb changes to an NSIP where you see this sort of subpleural sparing, lots of involvement of ground glass and moving away from the subpleural regions towards the central. You can see areas where you have LIP, where you have actually cystic spaces with small dots that are around them that are probably areas where an airway has been damaged. And then you can also see organizing pneumonia. So really there is a very, very wide range of presentations that's possible. There's a lot of consequence, and we talked a bit about this, about whether the pattern can tell you about the likelihood of disease progression. And this is one of a number of studies that suggests that a UIP pattern may actually portend a worse outcome than, say, an NSIP pattern. And I think a part of this is really thinking about when we look at the pattern, how does that influence our decision making? Like, if we see a UIP pattern, are we immunosuppressing to the same degree? Are we switching to an antifibrotic earlier? This study was done in 23, was historical. So presumably a lot of these patients were not treated with antifibrotics. But I think we have to really be careful about whether it's the pattern that causes the outcome, or whether it's our response to the pattern that causes the outcome. And then I just wanted to leave you with some reminders about predictors of disease severity and development of ILD in patients who have RA. This is something that I think that we've learned over time, certainly advanced age, male gender, higher titers of rheumatoid factor. If the patient is ACPA positive, certain HLA groups are more likely to progress. Very critically, smoking. I don't know how much this is a problem in the populations that you're seeing, but we have a huge amount of smoking, and trying to get patients to stop is a very big issue. Obviously, people who present with lower lung function are more likely to be progressive. Obviously, evidence of worsening PFTs over time, more of the lung being affected, and diagnostic delay. And again, this raises this question of whether really what the problem is that we're just not treating early enough. And so this is a study now a number of years old from the US, but basically what it is showing is that if you look at mortality in the US related in patients who have RA, actually the overall mortality rate is going down, but the mortality associated with RA-ILD is actually going up. And I think that we've seen this natural history in a number of other autoimmune diseases where we get better and better at dealing with the comorbidities, but ILD is really one of the most challenging comorbidities. And as a result, that is now becoming the more critical part in terms of survival. And I think that that's it for my slide deck. So let me turn it back over.
Thank you, Sonia. That was a super quick, comprehensive summary, I must say, on RA-ILD. I really enjoyed it. I think a lot of important messages. We have a question related to that. Sonia, I'll put it straight to you. From Asmita down south in the country, KL6 predicting occurrence of ILD in RA, as well as progression of disease. I think this biomarker is becoming available in India pretty easily. What is your thought?
Yeah, no, I think KL6 is a marker of epithelial injury. And so I think that it actually does associate with, active lung disease, which is often progressive lung disease. I think that the question is how easy it is to get it and when to actually test it. So, if you have a patient who's flaring and you check their KL6, it's going to be very high. That doesn't really help you. What you really want to look at is a patient who walks in the door and what their KL6 is, because that tells you where are they going with it. So I do think that it has a role. I think it's the timing you have to think about.
So you're saying a baseline value that could predict progression?
Yeah, I think that it's more valuable in that setting, because once somebody is already very active, it
Yeah.
tells you what you already know. And what
Yeah.
you really want to know is what is going to happen, not what is happening right at that moment.
So a baseline value and then prospectively. Great. So, Shenoy, I just wanted to ask you about her second case. No significant joint involvement, but significant pulmonary disease. What is your biggest challenge, Shenoy, in your practice managing such patients?
See, joints are easy to control, but lungs are not that easy to control, especially in rheumatoid, for
Okay.
sure. Joints, we have a lot of options. If you look at lungs, we have limited options, and our experience regarding management of newer drugs is not that high as what we have in joints.
Sure.
So my first option would be rituximab, and if the patient fails, probably add on mycophenolate. That would be the option in this case.
Okay.
And this combination usually works really well.
Sure. And, Vijay, over to you, your INPF registry, we always thought fibrotic HP was the commonest ILD in India till I saw your data when you presented it last year. And that suggests that CTD ILD is arguably now the commonest ILD in India. And what is your thought? Have you been able to dissect that data? How much of that is RA-ILD, and what are the implications you feel for pulmonology practice, Vijay?
So, Sujit, once you send me the question, so I tried to look the data. Otherwise, we were still cleaning the data because it's a huge data set.
Right.
And when we start looking at, then many things are missing. So we are trying to make it as complete as possible.
Right.
To cut story short, we saw that CTD-ILD is the largest number. Percentage-wise also, it's close to approximately 30% approximately overall. And among CTDs, we found that scleroderma is the commonest one. It constitutes approximately 37%.
Okay.
And RA is the number 2. It constitutes around 21%. So there is approximately 10% difference between 10 or 15% difference between these two diseases. So this is where we are. What we can take from this is, it may be few reasons why CTD is more common at one institute and hypersensitivity pneumonitis is common in other institute and sarcoidosis is in other institute. So one of the commonest thing which may be contributing is probably the referral bias. For example, one of our center, JIPMER, they are only getting patient with CTD-ILDs. They are a huge autoimmune clinic or immunology department who are referring all the patient to them.
Got it.
So when I was trying to see the data, so almost 70-80% patients from that center were CTD-ILD.
Okay.
So at our institute also, rheumatology department is very strong and we have very good collaboration with them. So they send lots of patients. So this seems probably the number one cause. The second may be how much we evaluate, and probably all pulmonologists, I'm sorry to say this, but I'm not saying they don't know, but sometimes our rheumatology training is not so good. We just see UIP pattern and we directly jump on to its known as IPF. We have seen few patients like that. So that may be probably this can be another factor, although it's coming down with lots of MDDs and lots of awareness because of that.
Sure.
And then maybe if we see hypersensitive pneumonitis, if we talk about C2 study, they probably evaluated little in more depth. And the questionnaire was little bit questionable, although that was a very good study and there was lots of criticism why the hypersensitive pneumonitis was number 1. So depending on what kind of setup you are working, kind of evaluation you are doing, probably these may be the reasons.
Sure.
So, but overall, if we say that more or less 4 common causes of ILD remains the same:
Sure.
sarcoidosis, hypersensitive pneumonitis, connective tissue disease, and IPF and NSIP. These are the 4 common causes of ILD. So
Sure.
more or less, maybe once you start doing studies, the percentage keep on changing, but 4 most common will be this one only.
Sure. And Shenoy, we are seeing more and more use of tofacitinib by some rheumatologists, and and newer drugs. So now you have the ACR ILD specific guidelines, then the broader EULAR network. How do you see this panning out, especially for selecting drugs with subclinical ILDs? There's some retrospective data saying that tofacitinib may actually reduce the incidence of ILD. Do you think rheumatologists are reading into this a lot and therefore prescribing it?
No. They are prescribing it because generic versions are very commonly available, very
Okay.
easily available. The cost of therapy is less. You can
Right.
take it 2 pills a day, don't have the pill load. But there
Right.
is a lot of data to suggest that tofacitinib should not be the first drug of choice, and it is
Right.
being really misused.
Right.
For Dr. Danov's reference, it will be hardly $40 per month. That's not $20, $25 per month is the cost of JAK inhibitors in the country. So
Wow.
it's very, very low. $25 per month is incredibly cheap.
And with that oral surveillance trial, I remember.
Yeah. With coronary artery heart disease increased,
Yeah.
MI increased, with
Yeah.
lot of tuberculosis, lot of herpes zoster. It should never be the first choice for
I
sure.
have had 2 patients having TB, and the rheumatologist said it never happens. I said, well, probably they're not going back to you. And so I
No, this is very common. It is very common
Yeah.
for if you take the world data and Indian data, despite excluding in randomized control trials, the risk is around 1 to 2% per 100 patient years. This is not at all uncommon. After excluding the latent TB, I'm telling.
Right.
And herpes zoster is terrible. So we should be very cautious in using tofacitinib, but it's a very useful drug. I'm not telling it's a bad drug. It's a very useful drug. In scleroderma ILD, we have in MDA for dermatomyositis, fantastic RP-ILD, just reverses. It's a very good drug. But like steroids, they have to be used with lots of caution. It comes with a lot of baggage.
Sure. No, thank you. That's important. Sonia, a lot of questions on biomarkers. And there's a growing interest, and we know we have the traditional rheumatoid factor, CCP, which help us. So is there any biomarker that can help us identify a patient higher risk for disease progression? And if there is, which one would you really zero in on?
Yeah, I think the future is biomarkers. I think the present is not biomarkers, unfortunately. I mean, even with KL6, I mean, I think that to a large degree we have very good demographic and serologic markers of who is going to progress. And I think that eventually we'll get to a point where there is probably not a single biomarker, but a cluster of biomarkers that help us understand who is most likely to progress. I don't think we're quite there yet. And in terms of clinical practice, that's not the direction I would go. I think that, the things I would think about are just being absolutely sure about your initial diagnosis by, appropriate serologies and, working with your rheumatology colleagues, and then, making thoughtful choices in terms of initial therapeutics and very careful monitoring afterwards, both in terms of toxicity as well as efficacy of the therapy. And I wish I had that perfect biomarker. I don't think it exists yet. And if you know of it, I'd be delighted to hear about it.
I don't, and I would agree with you. So we are reaching the end of the webinar, but I will take the liberty of extending it for 10 minutes, and I can understand if the faculty have to leave, that's fine. Whoever is left, we will address those questions to them. But I will end at 8:10 India time. There is also a question. What are the checklist pointers that you would lower your threshold to bring a patient to MDD? I think you did present those cases, but is there certain cases that really lower your threshold to bring to MDD, Sonia?
Yes, definitely. I mean, I was interested, Dr. Hatta's comments about the changing of the patients that are presenting to your, to your different institutions. And what we found is that we rarely see common disease anymore. And so I haven't seen just a run-of-the-mill IPF patient in quite a long time. And I think that that's actually really good. I think that really means that our colleagues in the community are very comfortable with that. But
Right.
so what we use our MDD for are patients where there are really either diagnostic or therapeutic questions. Because you're right, you can't possibly see everybody in an MDD. We have used it, unfortunately, increasingly as we have really critically ill patients. We get a lot of referrals to our MDD from our hospitals and our ICUs, where there's really significant sort of therapeutic dilemmas in patients who are very, very ill. And I think that that's also incredibly helpful. So not just the ambulatory patient, but in those situations where there's a hospitalized patient, where you just really need a bunch of people to think carefully about how best to proceed in terms of therapies.
Sure. Vijay, do you run an MDD at AIMS, and are there reasons you bring them more often to MDD?
Yeah, we have a regular MDD. We do MDD once a day here with the radiologist and pathologist.
Oh, fantastic. Every day.
Wherever samples are there, then pathologist will be also be there. Otherwise, most of the time it is pulmonologist and radiologist we do it.
Sure.
And at least those CT scan which are little not classical.
Yeah.
All those CTs are discussed with them at least once, first time at the presentation, so that we understand what can be the pattern and then maybe differentials. And then if we agree, then we stop there itself. But if we not agree, especially if they are saying it is NSIP, that is also especially idiopathic, then those patients, if they are fit, I subject those patients for some kind of sampling, at least BAL.
Okay.
And if patient is fit, then if patient is fit, then we also try to take lung biopsies. And most of the time it is cryot TBLVs.
Sure. Right. And I put this question to all of y'all, actually, and especially Sonia mentioned about getting critically ill patients to MDD. Vijay, you heard that.
Yeah.
That makes up the thing of, is this a patient that there are any particular challenges or certain red flags or things that a pulmonologist needs to look out for when referring to transplant, Sonia?
That's a really important question. I think that what I like to do is really have those kind of discussions early with our patients, because we hope that we're not referring them by the time that they're critically ill, and the evaluation takes so long that you really want it, at least if you have a patient for whom they appear to be progressing, there's, especially for an autoimmune patient, there's a huge amount of workup needed to make sure that their systemic disease is not going to actually interfere with their, suitability for transplant. And so I do, anybody who has progressive decline, patients for whom they're already, when I initially evaluate them, they're already using a lot of oxygen. I know those are the patients where we're going to need to make a decision about transplant. And unfortunately, for a lot of our autoimmune patients, not necessarily RA patients, we've managed to be actually pretty lucky with that group. But for some of our patients who have rapidly progressive lung disease, their comorbidities are so significant that they really are not appropriate for transplant. Those being things like esophageal dysmotility, significant, very severe pulmonary hypertension, really significant skin involvement, which makes them at high risk of infection. So I think you really do, if you have a patient like that, you really need to think very quickly about whether that person should be seen early for a transplant evaluation, and whether the comorbidities can be mitigated and make them a successful candidate.
Sure. Vijay, Shenoy, have you sent any of your patients to transplant from your?
I have sent a couple of them, but none of them got transplanted, because what happens then, I'm not very, being very frank, I am not very, it's patients, once they, about the cost is really.
They're all paying out of pocket in India.
Out of pocket, 25, 30 lakhs, 40 lakhs, and the 5 years of survival, 4 years survival, how much they really, we are able to give it to them. So yeah, till the more the data comes out and the cost comes down, definitely it's a choice, but not probably yes.
Sure, sure, sure.
So, Sujit, we have a active lung transplant program, running program.
Yes.
But we have done only few because of various reasons. Till now, we have not done any lung transplant for patient with RA-ILD. We have done few on fibrotic HP and bronchiectasis. So till now, we have not done. And one thing I'm not very sure, although the patient can have advanced lung disease or ILD, patient requiring oxygen or sometime NIV also. But most of the time, these patients, the connective tissue disease ILD or RA-ILD, they are
Right.
unpredictable. So
Sure,
it is very difficult to convince patient at the onset,
sure,
even if it is progressive fibrosis, because we don't know whether this is going to progress further or not. So
sure.
I am not clear whether this patient is a right candidate for lung transplant or not. So I feel difficulty in convincing patient when I am not convinced.
Yeah.
So
So
that is
we,
one
yeah,
aspect also.
I agree, Vijay. We start with the conversation because because patients are paying out of pocket in India, the transplant referrals, Sonia, you would realize often results in a transplant evaluation, which patients are not comfortable with on day one, And so then that conversation has to begin slowly, as Vijay said. I couldn't agree more. Aditya had a question from Mumbai that a patient that MTX is the first drug of choice, methotrexate. And is there any way to differentiate that this is RA or identify a patient with RA who may develop methotrexate-induced lung injury? Is there anything for that, Sonia? Have there been any early clues to that, Shenoy, in your?
No.
No, right. So
So,
there's
I
except
don't have any
monitoring.
existing lung disease, elderly age, probably at a high risk, but
Yeah.
not very.
Sure, sure. So the other
But-
question was on sorry, Sonia.
Yeah, I was just going to say patients are the best ones to tell you whether they have pneumonitis because you
Yeah.
only take the drug once a week. And
Correct.
so if the patient tells you that they cough in the couple of days after they take their methotrexate, you know
Yes.
that they're developing pneumonitis. And so I find that my patients actually often will tell me if there's a problem.
That's right. That's absolutely right. Asmita had another question about UIP patterns with significant joint problems. Would you give only methotrexate, Sonia, or you would? I recollect you did mention that you wouldn't jump onto the antifibrotic initially, but would you just monitor lung function on methotrexate?
I would definitely monitor lung function. I would talk with my colleagues, especially if a patient has active joint disease. Really, I mean,
Right.
I think that there's in RA, and much credit to our colleagues in rheumatology. They really have treat to control. So, their disease, because it impacts so many different organ systems, if you get good joint control, you get decreased risk of cardiac disease, interstitial lung disease, all of these other things. And so I think that the critical point is really having those conversations with your rheumatology colleague to make sure that you've got really good joint control. And then you can kind of go from there in terms of thinking about whether their lung disease is progressive, in which case you may ultimately decide to use an antifibrotic, or if their lung disease actually stabilizes once you get really good joint control.
Super. Makes sense. So another question from the north, in the last 2 minutes. Should you do a body box for all patients with ILD, a body plethysmography? Because we realize that a lot of your patients are obese, at least the two cases you presented. And I understand BMIs are higher in the United States than our country. But do you recommend routine body plethysmography?
So I think that there are really two questions here. I think we do lung volumes at least once with our patients. And just because you want to really be sure if the patient ends up having obstruction, whether they're actually really restricted or not. And so having that lung volume is actually very valuable. But once we know that a patient doesn't have significant obstructive disease, we actually typically do just a spirogram and a DLCO for their ongoing monitoring. And whether it's more important in patients who are obese, I actually can't speak to that. I think that we, since most of my patients are obese, I think that it kind of applies to every patient I take care of.
Yeah. Thank you. And just a final comment from you all. Thank you all so much for ILD is, as we all know, an emerging subspecialty in respiratory. There are many youngsters tuning in. Sonia and Vijay, especially to the pulmonologists here. Do you see this as a subspecialty in respiratory medicine that pulmonologists could seriously look at? Vijay?
I think it's the greatest field in the world. So I'll have to let Vijay answer that also. But I think there's the most amazing progress in the area. So I'd love to hear that you have many people who would be interested in going into it. Vijay, your thoughts?
Yeah, I think, Sujit, this is the most complex topic. If you see,
Yeah.
managing a patient of ILD, I feel it is more complex, most complex even. So although IP is taking kind of the glamorous role, but
Yeah.
I feel if you are a true pulmonologist, your efficiency will be checked when you are managing a patient of ILD.
Fantastic. And Shenoy and Sonia, one last
I
question
think-
on. Yes,
Yeah.
yes, Shenoy.
I think it is extremely important to be in a growing specialty where there is a lot of changes coming, and
Yeah.
ILD is the one a lot of developments are coming, and a lot of immunological drugs are being discovered. So I think more and more pulmonologists should take this up and set up a good ILD units with pulmonary rehab, everything together. It's a need of the hour.
Absolutely. I remember pulmonologists visiting India some years ago saying that you won't need anything more than formoterol budesonide for asthma for the next 20 years. So that's the time to move out of asthma. But there is things happening there, but for a minority of patients with asthma. Any targets, trials? Final question to Shenoy and Sonia. Y'all are reading in this space, Vijay as well. Any targets, trials that you're waiting for in the near future?
Not in RILD.
Not in RAID, Sonia?
So I mean, we're seeing trials in progressive pulmonary fibrosis that will encompass patients who have RA-ILD, and I think that that's going to give us potentially some new therapeutic targets that are very exciting.
Fantastic, fantastic.
Or,
So I think that's, yeah, when the patient progresses, that's where we need to really watch out. Vijay?
yes, I am also starting a trial which is multi-center, and it is also involving PPF, and we are trying to see whether enhancing the immunosuppression versus adding antifibrotic, which one is more effective, or it is equivalent or inferior, we don't know. So
Fantastic.
we are about to start. The center has been chosen, ethical clearance has been done. We have got the funding also. So in next 1 or 2 months, we will start recruitment of the patient.
That's outstanding.
Fantastic.
That's outstanding, Vijay. And thank you so much. Sonia, Saturday morning, and Vijay and Shenoy on a Saturday evening.
Thank you.
I cannot thank you all enough. And our audience, a lot of them across the country and outside the country who've joined it. Thank you very much.
Thank you.
Good night and
Good
good
night.
Thank you.
Bye-bye.
Thank you, everyone.
Bye-bye now.
Bye.
Bye.